Hi everyone, welcome to this episode of the Reflology series on glomerular diseases. So we are very privileged to have Dr. Chua Ruey, a nephrologist, who will be having this discussion with us. So maybe we'll have Hazel to start us off with the first question.
Yeah, so common question that a lot of us have is actually how common is glomerulonephritis in the patients that we see?
Hi. This is Horng, and so before I start answering the question, I just want to emphasize two things. That with this day and age, as things advances, every year we probably need to review what we have learned and make sure that it remains current. And the second thing is that I'm 10 years past exit. Now we think GN is common. We can't tell you how many CKDs we have in the country, although we are starting to track it. But in this country, we track the end-stage kidney disease fairly accurately, and this is available online on the Singapore Renal Registry. And you will see that glomerulonephritis still forms the second commonest cause of kidney disease, or at least end-stage kidney disease in the country, and second to diabetes. So as we speak, the latest census from 2018, I would say GN occupies or accounts for 14 to 15, 14 to 15% of end-stage kidney disease. Of course, diabetes is an overwhelming 65%. And more interestingly, if I were to just ask you to refer to a paper that's published by Wu King Tai from GH last year that tracks the what is it? The healthcare landscape for GN over 4 decades in Singapore. And you will see that IgA nephropathy still forms about 20 to 40% of all the GNs for which we biopsy in this country. And IgA remains to this day the commonest glomerulonephritis of those that we biopsy around the world. And we're not even talking about those that we don't biopsy. And with the increasing prevalence of kidney disease in the country, and that the GN percentage still remains the same, we have to assume that glomerulonephritis is increasing. At the same time, we also see a trend of things that, Singapore has evolved very fast over the years. 4 decades ago, we see a lot of GN that's so-called related to infectious-related complications and including parasitic infections. But now we are seeing a trend where we're not sure whether it's you taking processed foods or the lifestyle has changed or the environment antigens have changed. We see a pattern of GN that's more immune-mediated as well as metabolic syndrome. Okay. So the disease spectrum has morphed and changed. And I would say that in conclusion, yes, it remains a commonest, one of the second commonest cause of kidney disease that we see. It forms our bread and butter. It's a particularly tricky situation. Many of them go with no symptoms from time to time. The prevalence also depends on your country's screening process for army boys, for pregnant ladies, for insurance, by insurance agents. So in summary, yes, we think it's common enough for us to draw attention to it.
Okay, thanks for the very helpful epidemiological perspective to things. So the next question is sort of a broad question of when we should be suspecting GN. I think for most junior doctors, when there is a profound AKI or let's say hematuria, these are some of the things that may prompt people to think about it. But are there perhaps more protein manifestations or instances where we should be thinking about GN too?
Yep. So I was thinking about how best to answer it because there's a big group of them who are asymptomatic, and asymptomatic, the prevalence depends on how you screen for them. So I usually give the answer as the 2 groups, those who are lucky enough to develop early, or 3 groups, those who are lucky enough to have early signs and symptoms, meaning that you manifest early with nephrotic and nephritic syndromes and you show up early such that the proteinuria is so severe that it induces a degree of anasaka that you cannot possibly ignore and you see a doctor, or the nephritis occurs so severely that it compromises kidney function such that they manifest with signs and symptoms of fluid overload, and the AKI becomes evident, and then they see a doctor. And when you see them, and that's when we woke up and we find all the raised creatinine, the kidney dysfunction, the proteinuria, and hematuria. The second group, which is probably the so-called the lucky ones who go for health screening, meaning that those mandated by our government and those who are mandated by various work agencies or schools for which you apply to, they pick up the asymptomatic proteinuria and hematuria, whereas the third group will be the more unfortunate ones. The unfortunate ones meaning that they have the low grade or moderate grade degree of proteinuria and microscopic hematuria, but it goes unnoticed. They go for no health screenings in their life until they develop hypertension. And that's when they go for young hypertension workup, and then they found their kidney disease. So one key thing to note is that the absence of diabetes make it very unusual, or rather not common, for you to get kidney disease in this very country. If you have no metabolic disease, no diabetes, no long-standing hypertension to drive atherosclerosis, but yet you have an abnormally raised creatinine, especially that it comes with proteinuria, or it comes with proteinuria together with hematuria, and it need not be gross hematuria. It's most of the time microscopic hematuria. So these are the times that you have to think that there's probably some undiagnosed glomerulonephritis that deserves some degree of further probing and investigation. And what I hope through this series is that these cases do not just get lost in the community because of a guy being labeled as a dehydration with raised creatinine, asked to go back and drink more water, come back in the clinic, and then he subsequently is so-called gets better, and then they are discharged from follow-up. And that shouldn't be the case, because it is not usual at all for you to get kidney disease if you do not have the necessary comorbidities. So the absence of diabetes, but yet still having significant proteinuria or plus and minus microscopic hematuria, and especially with abnormal kidney function, these cases will deserve a workup for glomerulonephritis.
I see. So interestingly, you mentioned only diabetes and not hypertension. So when there's hypertension in some of these pictures, the question is whether the hypertension is the chicken or the egg. Is that correct? And most of the time, what you're alluding to is that it may instead be an outcome rather than primary hypertension driving these renal problems.
We need to understand when we label someone as hypertensive kidney disease, is it really truly hypertensive kidney disease? Because you see us writing this in the notes, but you don't see a biopsy to prove it. And you wonder, how do we make a diagnosis? So a lot of times, hypertensive kidney disease has been loosely labeled along with different terms. And what are these different terms? We call it ischemic nephropathy, likened to a ischemic heart disease, or we call it atherosclerotic kidney disease. And these cases often have renal vascular disease. So just by virtue of such description, these patients tend to be older. They tend to have years of hypertension, and you can't tell how many years they have. Most of them have undiagnosed hypertension for years, and by the time they manifest the hypertension, often with end organ symptoms and signs. But you need to have some adequate exposure to hypertension. You should have concomitant issues that's related to hypertensive organ injuries. They might have left ventricular hypertrophy. They might have other forms of macrovascular diseases, including peripheral vascular disease, ischemic heart disease, cerebral vascular disease. They are usually a bit older. The kidneys tend to be scarred and shrunken. And many times, hypertensive kidney disease, if the blood pressure is already adequately controlled, they are usually not heavily proteinuric. It's usually in the range of less than 1 gram a day, and there shouldn't be active signs for glomerular hematuria unless the blood pressure is acutely untreated, and then they present with hypertensive urgencies. You see what I mean?
Yeah.
So if the patient comes to you quite young, lack the longitudinal exposure to years of hypertension, show no signs of left ventricular hypertrophy, nothing much or quite clean in terms of other macrovascular disease patterns, has significant proteinuria, comes with variable amount of hematuria which we'll discuss a bit later what it means by hematuria. There is no reason for us to label them as hypertensive kidney disease unless you're taking a shortcut.
Okay, got it.
Yeah. So that's why I'm saying that if there's no diabetes, you are right down to these other top two causes. Second is GN, third is hypertensive kidney disease. You make the distinction by going by these different age profile, disease profile, concomitant diseases, etc. Now, it's worthwhile to note that the fourth cause in the country for end-stage kidney disease is polycystic kidney disease. But you do know that there's a family history to it most of the time, not all the time. There are age-based criteria for kidney cysts if they have family history. Yep. And if you do imaging, you see multiple cysts that's inappropriate for the age, you roughly know that you are probably gunning for something else.
Okay.
So with that in mind, just going by simple history, examination alone, and investigation, you can probably tell who are the ones who are likely to be GN and need to be woke up.
Okay, understand. Thank you.
Okay, so now let's say we see a patient and we suspect that the patient has glomerulonephritis. What are some of the basic initial evaluation that we should do so that we won't miss anything out?
Okay, so I was going through your questions just this morning. Thank you very much. And I was thinking about the two groups that we see. So we probably encounter them in the hospitals when they come in through the A&E due to other reasons, or versus your family medicine colleagues, or most of us who sit in the outpatient clinic, or when you're locuming, you see them coming to you. I feel that when they come to you in the clinics, it's usually that they have symptoms of something. And as what I explained to you, the edema is something that people cannot ignore. the dependent edema, because it's particularly bad. And so these cases that come through the clinic and they have this edema and signs of blood pressure may be low or high depending on whether it's a nephrotic nephritic presentation, or versus someone who comes through A&E due to other reasons, other symptoms, and found to have incidentally raised creatinine, and then they dig further. So you need to combine the kidney function assessment with quantification of the proteinuria. So the first point is that you have to quantify and prove that there is proteinuria. And the best way that you could get a quick answer, unfortunately, is a spot urine protein to creatinine estimate, by what we call a urine protein creatinine ratio. Now, the challenge with the ratio is that when you do it at different times of the day, we think there is an orthostatic component to it. There is also an activity-based component. So the more active you are, the more aggressive you just did some sports or some activity, you may have some degree of proteinuria. You do it later in the afternoon, you can also have some variable degree of proteinuria. You do it when you are sick, you can also have some degree of proteinuria. So, but it's a quick screen test, because if that is negative, then you are more or less sure that, well, I think there's no proteinuria, because the tendency is that you likely will overestimate rather than you underestimate. Now, the urine protein creatinine ratio hinges on the assumption that your denominator urine creatinine is in a steady state, and thereby you can use it to normalize the protein concentration in the urine. Because you and I collect urine at different times of the day. You drink more water, urine is more dilute. What does it mean to have a spot urine protein concentration without normalization? So we normalize to urine creatinine. We assume that a so-called normal individual excrete about a urine creatinine about 1 gram a day. And therefore, we think that the ratio, if you calibrate in terms of grams of creatinine, will give you the amount of protein, aka grams a day of proteinuria. So for example, if I say my UPCR is 1.5 gram per gram of creatinine, or 1.5 grams of protein per gram of creatinine, that becomes roughly about 1.5 grams a day of proteinuria. And thereby, you also need to tell your trainees or your guys to look at the unit that is reported in, because somehow in this area of the country, we report the urine PCR in milligram per millimole of creatinine. And that confuses everyone, because the unit changes, the number also changes. So that they do an adjustments back to the ratio. So look at the range, and from there, see whether it's out of range, because we usually give the normal range there on the screen for you. Now, if the proteinuria is very high, let's say you get a very bizarre high number, the correlation with the grams per day cannot be assumed. So I would say that if the suspicion is high, apart standing for a spot urine protein creatinine ratio, concomitantly we'll start to run a 24-hour urine total protein. Okay. Is that fair enough? Yeah, 24-hour urine protein, you also need to see whether the guy is or the lady is continent, because some of the ladies are not very continent, and you can't expect the helper to be waiting for the pee to come at the bedside for 24 hours a day. So these are the limitations that we still have to use a spot estimate, unfortunately. And if your urine protein is high, but you're not too sure whether it's really significant or not, then take a look at the serum albumin. Because in nephrotic syndrome per se, or most of the GNs, a great part of the proteinuria is actually in the form of albuminuria. And they lose quite a bit. They actually lose a lot, but it's because your tubules actively resorb the albumin. That's why when it comes out of the urine, it can be the range of like half a gram, 1 gram, or 3 grams, or 4 grams a day of albumin. But the serum albumin is enough to drop, because they're actually losing a lot in the glomerular filtrate. So a low albumin, in the absence of any other acute illness that can confound the albumin, because it's an inflammatory marker, that will probably tell you that this is really a likely case that kidney is of disease. You get it so far?
Yep.
Yeah. Now the next thing is hematuria, and that's a bit of challenge, because our UFIM or the urinalysis here is machine read. No? I don't know how to read it, because in the guys trained here locally, we were not taught to read the urine samples ourselves. That was many years back. I mean, now things have changed. Whether the US trained guys, they like to look at it, but I personally I hate to look at urine. So they report microscopic hematuria, and you got to think about it and go back to read the books about urological guidelines of who are the ones at risk of mitotic disease. The last thing to want is to blame it on the kidney, and you lose track of urothelial mitotic disease, or you forget to route a urine calculi in the individual. We may do a phase contrast, but phase contrast is also subjected to the limitations of a operator viewing the slide and giving you a percentage of RBCs which are dysmorphic, i.e. more glomerular origin, or isomorphic, i.e. more likely to be a urothelial tract origin or bleeding. So knowing the dysmorphism or the isomorphism of the RBCs that you detect does give you a clue whether it's of glomerular origin.
Is there a
Having
numerical
said that,
cutoff in terms of
yeah,
what is
so
significant?
you probably know it better than me. When you read books, you see like 70% or so. I don't mind telling you, I don't think it's a highly reliable number. I've seen publications saying that it's good, some publications saying it's bad. So I would say that as long as there are some signs of dysmorphism and there's concomitant proteinuria, you've got to assume that there has to be some glomerular origin. That's number one.
Okay.
Number two is, if the patient comes with hematuria, and regardless of whether it's dysmorphic or isomorphic, if it's a at-risk group, so what are the at-risk groups? Depending on which guideline you read, you have either a 35 or 40-year cutoff. The older patient, especially chronic smokers, who are exposed to certain industries that involve the toxins to the bladder, patients who receive cyclophosphamide in the past, patients who go for radiation to the pelvic radiation, and these are the at-risk individuals. Invariably, when we see hematuria, we would send to the urologist for a workup to make sure we do not miss a mitotic disease, just for the fact that we handle a lot of adult patients or middle-aged or older patients in this place. They would have a urological imaging done. Most of the time, urology will subject them to a cystoscopy, and they will do a CT urogram for them to make sure they clear out tumors before they send back to us. But if you have a quite clear cut of dysmorphic RBC with proteinuria in a young individual, especially if you see RBC cast, and that is probably something that we think, okay, this is likely to be more glomerular origin. And tell the patient, look, you're quite young, we're trying to reconcile investigations, etc., etc. If you're brave enough to say this is not mitotic, then you want to push to a GN, then so be it, and hopefully you're correct. Yeah, and that brings us to the next point that you asked, what are CARs? So you must understand that urine is not just water. Urine, there's a lot of sediments in it. There's a lot of tubular proteinuria in it, and you read in the medical textbooks, they call this TAMS phosphor mucoprotein, and up to now I still don't know why it's called the name, but these are proteins or secretions by the tubules, and it's likened that you go into a rain, you step into the rain, you see puddles, but when the sun comes out, the puddle dries up, you see sediments there. It's the same thing concept in the urine. These are tubular proteins, and they won't just stay alone. They will bind to any cells or fragments of cells that comes out in the urine. So if you are bleeding, you got RBCs. The RBCs can be in the form of dysmorphic RBCs or fragmented RBCs. They bind with the protein, then they will form RBC cast. If there's a lot of white cells, which sometimes comes with tubulo-interstitial inflammation. So I was saying that the RBC cast make us suspect that this is likely to be glomerular origin. It's once you say RBC cast straight away, people imply that, look, you're already suspecting a GN. All right, and white cell cast could be invariably linked to tubulo-interstitial inflammation. We are not too sure about the significance of it. Okay. But bear in mind that you often see reports of highlight casts, and that's often written out in the urine FEME. And highlight casts are not very specific. It just means that there are casts there, I know, but they are not in particular or any specific cast, and they do highlight, and we are not too sure about it. Give me a while. Okay, so I just go through a bit. So you quantify the proteinuria. You look for concomitant hematuria. You have a thought in your mind whether you could confidently say that this is glomerular origin or whether this has to be worked up for urothelial origin of bleeding, especially in older patients, chronic smokers. As long as you have a suspicion of symptoms, I don't think you just leave it alone and just blame it on the kidneys. And if you find proteinuria, hematuria together with RBC cast, then it seems very likely that it's a glomerular origin. And unfortunately, we don't often read the slide ourselves, so you don't see RBC cast actively reported all the time. But the presence of highlight cast is not a very specific thing altogether, and we can't when you see that, you don't know what to react to that per se. Okay. Right. So work up the urine, prove that it is losing the urine already, and then subsequently please assess, determine the kidney function. Now, when I say determine the kidney function, it means that you have to be smart enough to trend it. Now, this is an electronic era, and many results are out there. It's just whether you take the effort to look through at it. So how do you know what caused the kidney dysfunction? You trend the blood test. You look for the acute dip in the kidney function, and you dive into the period. And when I say dive into the period, it doesn't mean to just go and click a bit on the and stuff. No, you go in and see what exactly happened to the patient during the time when the kidney function got worse. What did the physicians do? What did anyone do? Were they introduce new drugs? Did something happen to them? And most of the time, acute kidney dysfunction comes when someone is admitted to the hospital or when their drugs are changed. And you dive down to the period of time and you see what the primary care doctors or the other doctors were struggling with. sometimes you will find some clues like they were struggling with blood pressure control all of a sudden. They were struggling with more proteinuria where it wasn't expected from before. And then they generically, they will increase the REF blockade, but it doesn't work, and then subsequently they refer. So dive in and train the kidney function. And what I want to do is appreciate if the kidney function is shaky, because if the kidney function is shaky and there's a subacute dysfunction, it may not be a frank AKI, that will swing your intention to pursue more or even commit to a kidney biopsy.
Okay.
You follow what I'm saying?
Yep.
Versus someone who is cruising along for years, nothing happening, proteinuria is super low grade, then well, then maybe these are the ones that we say, hey, let's do the non-invasive test workup first, then biopsy urgency maybe is not too urgent.
Okay.
Yeah, so I would say that in the night, at least shows us that you quantify the proteinuria, do a urine analysis, do it early. Don't wait until the next few days in the hospital where you do all kinds of weird things to the guy, you catheterize him, you push in a tube, then you get all kinds of bizarre numbers coming out in the urine, kind of thing. Do all these tests early and give us a sense of what is the baseline, and then the rest of the investigations will take time to probe further.
Okay, got it.
Which comes to the next question, I think.
Yeah. So actually before that, the next question is about nephrotic versus nephritic syndrome. I mean, this is how we are typically taught in medical school. So maybe just a quick review of how they are defined. But I think beyond that, is this really a binary thing, nephrotic and nephritic syndrome? And what's the clinical significance? Because at the same time, glomerular diseases, does it then define like what are your likely etiologies, how you evaluate, etc.?
So that there are, and if you say nephrotic, you are describing a very particular phenomena, and it may really be something binary. And the only reason why binary is that because we handle adults, so many of them come with concomitant diseases like hypertension and already has some baseline kidney disease. That's why it becomes blurred and not totally like the true nephrotic presentation. Nephrotic is nephrotic. There's actually a mnemonic using nephrotic, but it just means that they are really swollen, anasaccharted, spacing away. They have very heavy proteinuria. Depending on which books you read, they are in excess of 3.5 grams a day. And the predominant protein in the urine is actually in the form of urine albumin. At the same time, they have concomitant hypoalbuminemia, and they have invariably some degree of dyslipidemia that we think is due to a disordered liver metabolism of protein in response to your heavy proteinuria that make it entirely lopsided. That's why they have clotting factors, irregularities, imbalance, and some of the severe nephrotic get clotting tendencies. Now, most of these nephrotic syndrome guys, because of a very poor oncologic pressure, their blood pressure tends to be really poor. So in my patients who flare nephrotic syndrome, they really hate it. Apart from getting swollen, the urine turns extremely bubbly and frothy, and they actually know that because once they see the urine turning frothy, they actually give us a call, hey, something is wrong. And the blood pressure goes a bit lowish, and it doesn't help that many of them we try to chronically give REF blockade over the years. So they get quite giddy and unwell, but because of other diseases, sometimes they may not necessarily get that borderline low BP or hypertension as they are older with comorbidity. So when you say nephrosis, it invariably gives us the impression that that's the case. But when you say nephritic, and just by virtue of the nephritic, the letter I in nephritic, it means that this is a more aggressive inflammatory disease, and it comes with variable amount of proteinuria. That's why you could have patients with nephritic and nephrotic.
Okay.
Because the proteinuria can be severe enough to be in the nephrotic range. They have low albumin, but at the same time, they have what we call active urinalysis. The urine has there's blood in the urine, there's cast in the urine, and the kidney function is a bit shaky. Invariably, there's some degree of AKI. It may not be exactly fulfilling your so-called numerical AKI definition, but the kidney function has dipped and dropped over time, over a short time of months. It may not be that acute, and I'm not sure whether it's because of kidney dysfunction and worse saltwater retention, etc. But they get some hypertension as well. So when you say nephritic, they can have nephrotic inside. But when you say nephrotic without nephritic, that means something to us. And what does it mean now? Because I hope I don't confuse you when I bring up this point. Now, when we say nephrotic syndrome, we are referring to a disease state that is more a podocytopathy, podocyte disorder. More a podocyte disorder that you think in a layman's way, it affects your filtration barrier. You can think about your glomerular membranes now becoming very leaky with the damage of the podocyte, right? And the slip processes are disrupted. You get heavy albuminuria. So we think of it as a podocytopathy or podocyte disorder, and then comes the associated reason how the podocytes are affected.
Okay.
But once you tell me nephritic, it's nephritic, then in my mind, I'm thinking about a glomerulus that is heavily inflamed. There's inflammatory cells infiltrate. And depending on which part of the gloms the inflammatory cells or the intrinsic cells of the glomerulus proliferate in response to a certain irritation, something irritated it. Some immune process has irritated it to become inflamed and proliferate. The cells proliferate. Depending on which part of the glomerulus the cell proliferate, thereby comes the histological terms. But that's after your biopsy. If it proliferates in the mesangium, you say mesangial proliferation. If it proliferates in the capillary loops, you call it endocapillary proliferation. If you get proliferation in the Bowman's capsule, God forbid, you call it crycentric lesions. So something irritated. What is the thing that irritated it? Was it immune complex? Immune complex, then you prove it, you're straight away thinking about lupus or IgA. If it's non-immune complex, hey, what's going on? No immune complexes, you're kidding me? Then you think about ANCA-related diseases, the vasculitis. So once you tell me nephritic, I'm thinking about inflammatory injury, and these cases are usually sicker. And bear in mind, your patients may not only come with kidney disease. I think the role of the on-call is to make sure there is no life-threatening extra-renal manifestations at the first go. And these cases will be a bit more urgent for a biopsy. And we probably may keep them in the hospital to biopsy and get a diagnosis in case we are missing something. And we have missed things before. We have missed things before. Things have gone bad before. So when you say nephritic, this is what I'm thinking on the back of my mind. And when you say nephrotic, now I'm thinking more like a podocyte disorder, maybe not so much inflammation. I'm sure there's still inflammation. That's how it damages things anyway. But not in those proliferative nature. So we call it a non-proliferative nature, or podocytopathy inducing nephrotic syndrome, or a proliferative GN with quite heavy inflammation inducing and causing a nephritic syndrome.
Okay, got it.
Yeah. So
related
to some of the things that you mentioned just now, I think it's important for residents to recognize on call some of the red flags that they should be looking out for. And with that, is there any red flags that needs to be treated urgently or even require urgent renal referral overnight?
We have lost lives because of pulmonary renal syndrome. We have really lost lives, and I tell you that when we lost lives, at the point of time the guy died, we still do not know whether it's a GN or some inflammation causing the pulmonary hemorrhage along with the kidney disease, because some of these are so sick that we couldn't diagnose. And pulmonary renal syndrome is really bad. I would say that the on-call probably want to pay attention not just to numbers, but pay attention to the presence of any bizarre symptoms that affect the airway and breathing and circulatory function, especially if there's hemoptysis that's unexplained. They do need to be a bit mindful, and when I say mindful, they can't do much as well, correct? No, they can't do much. The night can't do much, but at least you make sure that basic things are taken care of. And I know the hemoglobin, the platelets, coagulation profile, cross-match. You get all these tests done up and sent off. And maybe if you are really a very advanced thinking guy, I think to send us out onto a new screen. And when people see you the next morning, it's like, hey, this guy is thinking about something like that. But please put a cup by the patient. No, don't think about having all this Younker suction at the bedside. Get ready for all these things. So that's probably more important than looking at kidney. Number two is there is something ingrained in medicine that when we see a raised creatinine, we are very motivated to hydrate. And while this is generally true, but you must understand that you see patients in the AMU and the ward. You are not in the EMD. Unless you think your EMD colleagues are doing rubbish there, you have to assume that they have a fair bit of resuscitation by the time they come to you. And by the time they come to you, they are not in a virgin state, meaning that they have been touched and been given all kinds of things and fluids. So if the guy is robust and well perfused, the blood pressure is good, the decision to hydrate entirely falls on your assessment whether the guy needs or not. And you better pray that your assessment is correct, because if your guy is not a hypovolemic patient or the so-called pre-renal injury that comes in, and then you are just dishing out a liter of Hartmann's or saline just because of a raised creatinine, you better pray you do not overload the patient. And sometimes looking at the patient's blood pressure profile, the degree of perfusion, doing a proper examination to look for all the edema and lung and good auscultation. Now, it's not uncommon nowadays that I even see you not doing auscultation. And you see a hyponatremic picture as well, because hyponatremic shows that there is some degree of excess water in the body. So once you see these features, and if you are confident in your diagnosis, it may not be wrong to just give them a fluid restriction order rather than to flood more fluids.
Okay.
I.e., you give fluids based on your clinical judgment and hemodynamics and never based on the number. That's what I'm trying to say. So do not make things worse when you can't treat it at night. So rule out dangerous extrarenal manifestations such as pulmonary hemorrhage. Don't miss the myocarditis, but those are really uncommon. And if the kidney disease is something that's not entirely related to hypovolemia or dehydration, then perhaps you go on a conservative fluid approach and don't jeopardize things any further. And get some preliminary tests done up to give us a bit of reduced wait time the next day. For example, you send off a spot urine protein creatinine estimate just as a quick screen, or knowing that there are limitations to interpret it at night. Oh, that's true. But just as a quick screen, do a urine analysis, because that might just sway the decision to refer early tomorrow morning, then to wait until the next day. You know what I mean? Do some of these things, get the kidney function all done up, so that with this we know what kind of decompensation are we thinking about. Because you do it the same night, next day we could actually trend it. You may think that doing repeated tests is stupid, but no, we don't think so. Sometimes we just need to trend it and know things are getting worse. How do we know it's getting worse? The creat and urine may be climbing, but the sodium may be going worse. Sodium going down is a bad sign. Acidosis, kalemia. So these are things that we look for. Phosphate, uric acid. So that there's more than just a creatinine. And get some of your tests done to make sure that you're not missing cytopenias, because that gives you a sense that you're missing out something that's more systemic in the involvement.
Okay.
Do I answer the question? I don't know whether I answer the question.
Yeah,
you
you do.
Stop me if I going off tangent.
No, you do, and I think it sort of links to the
One more
bigger
thing
picture.
is that if blood pressure is very high, I think the on-call should sometimes try to do something about it rather than leave it alone. BP is very high, and the safest drug you know at night you can give is the calcium channel blockers, the dihydropyridine calcium channel blockers like amlodipine. Nifedipine is a bit long, I think. Sometimes I like to give a touch of amlodipine, because when there's kidney dysfunction, many of times we do not dare to give rest blockade in the middle of the night. And then I started people giving beta blockade to control BP acutely. So maybe some degree of low dose amlodipine, or even just a GDM patch. Or sometimes these are certain things that on call can do. Yeah.
Okay. And but maybe for the last question, do you think overnight there's any need for, are there instances where there's an overnight requirement for renal referral?
Do you think so? Have you seen such a scenario, right?
I mean, I guess unless
if
it's really
your guy is so sick to come in and all
probably would be in ICU lah.
Yeah, so the ICU referrals depends on which place you work with, and you really that bad luck to get a fluid overload patient, which we have, unfortunately. And yes, we have been triggered to decide on urgent dialysis as well. Otherwise, in the absence of pulmonary renal syndrome, I don't, and obviously, frankly, fluid overloaded patients with respiratory decompensation, I can't think of patients that you will not try to initiate some diuretics first while calling us the next day.
Got it. So that sort of leads into the next question, where we take a step back beyond the acute investigations and ask ourselves, how do we investigate further for the etiology? I think this is quite helpful because oftentimes patients may not end up in nephrology at the outset. They may end up under GEMAT care, maybe seen in the primary care setting. And let's say they're admitted inpatient. I think the first question is, we know that there are many conditions that are associated with glomerular diseases. The question is, do we do a bundle blast and look for everything? How targeted are we? And later on, further questions of like biopsy and imaging and stuff.
Yeah, it is not uncommon that nowadays we throw a fishing net and just do every single thing under the sun. And I would say that you have to think of what I said just now about nephrotic versus nephritic. Now, if someone has a nephritic presentation, unstable, and especially in the parents or unstable kidney function, your dumbbells sort of tweak and go towards inflammatory injury. So our patients, most of the time, they will undergo 3 or 4 classes of investigations for GN. The first, of course, obviously, is the autoimmune screen. Now, depending on which school of thought you are, because I think all of us were taught that if your anti-nuclear antibody is negative, then maybe you don't need to pursue the subnuclear components. But that's also in the assumption that your assays used in the hospital or in this country are all very reliable. If you practice in other countries with different assays, you may not be able to say the same. I've seen patients who get their anti-nuclear antibody and anti-double-stranded DNA done, and the results are opposite when they come here. You know, so it's just a bit bizarre situation per se, but they should have an anti-nuclear antibody done. And if your anti-nuclear antibody is positive, of course they will report to you what are the different types of speckled or homogeneous, etc., for which I don't even know how to interpret at this stage. But you probably have to pursue for lupus.
Okay.
So you invariably will end up doing an anti-double-stranded DNA, and you will do a complement to look for hypocomplementemia. Like the complements get sucked up by the immune response per se. Now, if your guy has unstable kidney function is getting worse, we would suggest that you pursue an anti-glomerular basement membrane antibody or the anti-neutrophilic cytoplasmic antibody. Now, I'll tell you why. Now, if you decide that you don't pursue, please realize that they only run the test once a week.
Okay.
They run it on a Wednesday or Thursday morning. You miss that window, you don't call the lab. They will just wait until the next week.
Okay.
And that has happened multiple times before. There was a period of time where they didn't run for COVID patient, but anyway, that's beside the story. Yeah. So if your suspicion is high, if the alarm bells are high, and you happen that you missed the window for the week, just give the lab a call and tell them, look, for some particular reason, we need this test to be done. Because in someone with kidney function is unsteady, in someone who has some bizarre respiratory symptoms or hemoptysis, and then the anti-GBM comes back positive, it changes the entire management for the weekend for us.
Yep.
We have to go and call the lab, hey, is this a false positive? What is the level? Because here they started doing qualitative assay now. So we try to send off a quantitative assay to understand, is this really a strong positive test? Because if it's strong positive, we have to regard that this could be, we could be missing an anti-GBM disease.
Okay.
You know what I'm saying?
Yeah.
So if the case is severe, especially it comes to AKI, then we usually will throw in the anti-GBM and the NCAS as well. Some people do the whole bunch of tests regardless of the acuity of the kidney dysfunction. As long as it's nephritic, they'll just run out everything. And I'll leave you to decide what is the better approach to do. Just understand that there are some constraints if you don't do it upfront. Now, if the patient is nephrotic, you still got to route lupus.
Yep.
Because lupus has nephrotic presentation as well. But at the same time, we do a anti-phospholipase A2 receptor, the anti-phospholipase A2 receptor, or the anti-PLA2R antibody, which is nothing new because that's been around for a decade already.
Okay.
And this antibody is to detect a particular, or to look at the antibody levels, look for antibody levels against a surface antigen on the podocyte called the PLA2 receptor. And targeted antibodies to this receptor induces membranous nephropathy and nephrotic syndrome.
Okay.
That's why we run this test. Now, we do not know the utility of just using this antibody to diagnose. So far, we have not broken through the no biopsy barrier yet. So we still subject the guy to a biopsy, and we try to stain for the receptor antibody in the biopsy as well.
Okay.
And this has replaced the term idiopathic membranous nephropathy, which is no longer in existence because we came to realize that most of this idiopathic membranous nephropathy was actually anti-PLA2R disease.
Okay.
You understand what I'm saying? Yeah.
Yep.
And in the rare case, we have found anti-thrombospondin antibodies, but that is not common, and we do not expect us to order it upfront.
Okay.
Sometimes the membranous nephropathy are related to anti-thrombospondin antibodies, and these cases have some association with underlying mitotic disease.
The PLA2R or the anti-thrombospondin?
No, the anti-thrombospondin.
Okay.
Anti-thrombospondin. There's some association with underlying mitotic disease. And that's more the case for nephrotic syndrome. So if you have a nephritic, I told you before, nephritic also comes with variable amount of protein, right? So it's not uncommon that you see us setting everything off. So we end up setting an anti-PLA2R as well.
Okay.
Are you all there with me?
Yep.
Yeah.
Yep.
So any form of GN, because hepatitis B and C can cause GN.
Both nephrotic.
How does it cause? We don't. Yeah, that's correct. That is correct. So how does it cause? We don't we don't really know. We think that there are antibodies formed against the viral antigen to form an immune complex lesion, and then it attacks or it affects the glomerular basement membrane.
Yep.
So it can cause membranous nephropathy and nephrotic syndrome. It can also cause membranoproliferative GN, so-called membrane proliferation, and induce nephritic syndrome. So when we get GN and we get active hepatitis B or C, we may elect to discuss with the hepatologist to treat the hepatitis B or C, regardless of their conventional liver indications to treat.
Yep. Okay.
It is also quite incredulous for you to give immunosuppression when there's untreated hep B and C. You will probably kill the guy. Yeah.
Yep.
Oh.
Understand.
Retroviral disease and GN, we don't see that often anymore because they're very effective therapies, and now we see more like therapy-related tubular disorders at the moment. So we don't see that much retroviral anymore. Now, because paraproteinemia can cause proteinuria,
Yep.
it can cause predominant albuminuria in the case of amyloidosis, but it can also cause Ben Jones protein as well. It really depends on what kind of kidney disease it morphs to. So we will end up doing a serum protein electrophoresis, immunofixation, and nowadays we'll do a free light chain ratio to look for an imbalance in the ratio. With kidney disease, both kappa and lambda will increase, but the ratio should be kept fairly constant. But if you get a discrepant ratio, that is something wrong. And we think that these cases might warrant a hematology review and a bone marrow biopsy.
Okay. And what about the para-infectious group? Is there any role in sending off the anti-streptolysin O?
So for any particular para-infection you're talking about, you are talking about post-infectious GN. This is not something that we could diagnose by a blood test because the post-infectious GN happens many weeks after. So I've encountered two in my life. One was following treatment for endocarditis, and one was following treatment for viral pancreatitis, or which I don't know what the cause of. And they came on with kidney dysfunction many weeks down the road. By the time they came in, the underlying disorder was so-called settled. But when you biopsy, then you see big immune complexes clumps on the capillary loops per se, and there's no test except for a biopsy to find this. And the treatment is also not very well defined. We dish out some steroids, but honestly, there's no randomized trials for this thing. So I'm not sure which para-infection you're talking about, but you're talking about post-infectious GM variants. We don't really have a test for them. I want to add something that I forgot to mention, that it'll be very funny that if I biopsy someone and I diagnose diabetes from a biopsy without having someone tell me that it's diabetic. So any GN that comes in, they deserve to have the metabolic profile screen. I mean, it's a bit funny nowadays that you don't check someone for at least a HbA1c, or at least you know what's the lipid profile in the patient before you do funny things to them. You know what I mean?
Yep.
Yeah.
Okay. And
I'm not sure whether I answered your question about the
yeah, you do.
thing.
I wanted to ask actually more of like the strep associated is normally more in the pediatric population, is it?
Yeah, so I've not seen one in my life, I mean, apart from, I'm not sure whether as a student, whether there was some PIDS cases in the ward. I don't know, no. And of all the anti-streptolysin O antibodies that we have done so far for the adults, we did a young one girl. We have one girl, one adolescent girl, and that was positive. I still recall, but when it's positive, the creatinine was already coming down and she was getting better. So in the end, we did biopsy also.
I see.
So we don't see that much in the adult setting. Our post-infectious GN adult are very severe. It's not like those they read in the pediatrics. They get severe AKI, they go on dialysis. They are not easy to treat, man. Yeah.
So the anti-streptolysin utility is probably a bit low in terms of the etiological workup.
But we don't do it commonly.
Sure.
Yeah.
Okay.
I mean, if they ask IT, then just take years, I guess. Yeah.
Okay.
And I just wanted to know, like, how about for imaging? Is there any role for any form of imaging for nephritic?
So, so it depends on who you're working for. So you obviously need imaging to understand whether the kidney cortex is good enough to biopsy. You get someone with scarred kidneys, and poor thing, we have seen scarred kidneys before. We have seen scarred kidneys in very young people before, and unfortunately many of them are foreign workers. And when you have very scarred kidneys, it's very hard to biopsy. I mean, I don't know what's whether it's really worthwhile to biopsy a scarred kidney to find scarring. So at least we would like to appreciate the cortical thickness, and we would like to appreciate that in the area that we're going to biopsy, there is no big cyst, or worse still, you miss a tumor. Now, we have seen kidney tumors before, for goodness sake, when the older, of course, in the older group as well. And it would be very funny that on the biopsy table, I see a hydronephrosis, and I already planned a case of biopsy. So most of the time, we would like to have a structural scan done to rub big cysts, polycystic kidneys for say, you know, it's very, very funny if you go on the diabetes table, you see a polycystic kidney. I want to at least know that there's a good contact. I want to at least know that both kidneys are present before a biopsy. So having said that, now we can do all this on the table. It's just that on the table, when we biopsy, we don't go at so many different angles. So you don't get a 3D view of the kidney because biopsy is, ultrasound is a 2D view. Ultrasound is highly dependent on your operator. Operator is highly skilled, go through different angles. You can even tell me the cyst, how good, how is it, and whether there's any solid component in the cyst. No. All I want to know is whether there are atypical lesions that I will miss. So most of the time, I will still send to get a formal ultrasound. Now, ultrasound expertise will change. So as you get confidence that you get a good person with expertise, then you can do whichever ultrasound you want. So in summary, yes, we will get at least the ultrasound kidneys to make sure that we don't miss out all these big things. If there's hydronephrosis, unfortunately, you got to send the guy for a CT, KOB, look for a utric lesion. You can't see that very well on the ultrasound.
Okay. And final question is, in terms of the threshold for renal biopsy, I think in the patient who is frank nephritic, we do know that there's an impending urgency. But I think what we sometimes struggle with would be the nephrotics that may fester and then, okay, maybe like TCU renal outpatient to see whether there's a need. So for that group of patients, what's your guidance?
So in children, you're always trying to find a reason to biopsy them. But in adults, you're always trying to find a reason not to biopsy them. So by essence of what you said, by default, all cases that undiagnosed kidney disease, we should offer biopsy. But then we take out by exclusion criteria. So what are these exclusion criteria? So you mentioned the kidneys are all scarred already, then we think that maybe it's game over, no point. So we give a death sentence to the patient. Oh, I'm sorry, maybe it's a bit too advanced. We had it for quite a few years, it's all burnt out. Let's just do best supportive treatment, and then we say this is a presumed GN. Or it's a very old uncle, who walk with the stoop posture, such that you give him the drop of prednisone, the entire bone will collapse on. Then maybe you tell him that, look, maybe I say maybe this is more hypertension related or hypertensive kidney disease. Then we just give you the best care, prevent the postural hypertension, etc., treat the constipation, kind of thing. Then after that, we just keep him happy and then kind of thing. So you got to see the case construct. What do we find? But if the case is suitable, and then you have to live with the dilemma of having an undiagnosed kidney disease for don't know how long, it'll be very funny they don't offer them a biopsy. Because for all you know, that may change how things are. Even when it comes to transplant, it's good for us to know the native disease because some native GNs tend to relapse. So most cases should be biopsied, all right? And if it's non-diabetic, straight away the threshold goes down for biopsy if you're non-diabetic with kidney disease. If you're smelling GN, straight away we also offer a biopsy unless you think it's quite advanced, all right? And if you are diabetes, wow, then that's a struggle. Then we have to think about, okay, how bad are your microvascular risks? Are they super bad? Do you have more things to worry about than me to worry about kidney, kind of thing? So think about this thing. So some of the guys, they have no legs and stuff, and maybe there are more pertinent things of concern, and just at the MI, taking aspirin and Plavix, I think 1 year of it, maybe not now, or maybe not now, maybe never, the kind of thing. So it depends on your certain case, but by default, we should. So you tell the resident, unfortunately, sorry, by default, you should offer biopsy for undiagnosed kidney disease.
Okay, got it.
To answer your question. Now, please bear in mind that the highest risk of bleeding for a biopsy comes with uncontrolled hypertension and with AKI state. So these are the two things that the highest risk of bleeding, and bleeding is not fun. You've probably seen before. It's very, very, very extremely depressing for both the patient and the operator. So we want the blood pressure to be well controlled. And if the guy has AKI such as the fluid overload state and BP can't be controlled by routine medication, the guy needs to be dialyzed. Or if it's quite badly azotemic, there's no so-called magical cutoff creatinine number, but we prefer to dialyze and make the numbers look a bit more under control. Let the BP settle down, let the risk be lower, be moderated, let the less edema, so it's easier for us to pass the needle through. Then we offer the biopsy a bit later.
Okay, understand.
And because it's a life-threatening complication that we quote them, it is perfectly understandable if the patient who is not super urgent to do a biopsy, they have some time to think over it and then come to the clinic early to rediscuss it.
Okay, yep, got it.
Okay, so now I'd like to ask some questions about the treatment. I think by this point in time, Reno will be on board already, but just for our learning, what are the types of treatments that you all would offer for the various conditions?
Yeah, so there was the guy with high dose steroids, and then the guy had some borderline diabetes kind of thing, and then the hyperglycemia, no one taught them how to even monitor the glycemia. No one tell them about the food they have to avoid. Sometimes I wonder who gives this counseling the ward inpatient, because outpatient, there are actually people giving this counseling, but inpatient, I see things being done up like in a bizarre nature. Now, rather than jump to immunosuppression, I always ask yourself whether have we offered the so-called best generic measures or the non-immunosuppressive measures for the patient. When the kidney function allows and is not shaky, not in AKI or not in very bad dysfunction state, we probably will offer them generic RAS blockade. And RAS blockade has been studied, I guess, the most actively in IgA nephropathy and maybe membranous nephropathy, but IgA nephropathy per se. So we will still give them maximally tolerated RAS blockade, and then we start a bit, and the outpatient will titrate upwards for them depending on how much they tolerate. Bear in mind that your RAS blockade will share a competitive risk of hyperkalemia together with your calcineurin inhibitors like cyclosporine and tacrolimus. So if you want to optimize one, you may not be able to optimize the other. We give the maximum tolerated RAS blockade. We advise them the importance of good blood pressure control and a low salt diet that can also influence proteinuria. We tell them that, look, if you are fat, maybe not a good idea anymore. When condition is better, please adopt a healthy lifestyle and adjust your eating habits. We dish out medications, or rather we work on measures to optimize your cardiovascular disease profile, because we are treating you not just for 1 month, 2 months, 3 months, but for 10, 20 years to come. And your kidney disease and proteinuria are long-term cardiovascular disease. So we prefer to optimize your metabolic health, give you statins if you need to, optimize your LDL control, advise you to not smoke, review your Framingham heart score and your overall risk factor, and adopt appropriate measures to tackle these things. In there's a severe nephrotic syndrome, very severe ones, fatty hypoalbuminemic, usually less than 25 grams per liter. Usually those with membranous nephropathy, don't ask me why. Recently, I had one case of minimal change disease to relapse with pulmonary embolism. But thromboembolic complications are not common, but they happen. So some of the severe nephrotic ones with severe hypoalbuminemia, we may advise them on anticoagulation until things get better, but well after your biopsy risk is over. Not just following a biopsy and then give them anticoagulation, because delayed bleeding has been reported after a biopsy. So work on some of these measures concurrently, and don't just get sucked in with dishing out super guns for we are excited about.
Yep.
Unfortunately to say, many of our immunosuppression induction protocols are steroid-based, at least for the first few weeks to few months. And steroids doesn't come with no risk. So that's why we say, please check your virology. And when we say check virologies, HIV and Hep C are quite straightforward. Hep B is the one that is a bit bizarre, because there's so many different tests to do for Hep B. So we at least make sure that you have an anti-core total antibody. Because it's not, at this day and age, it's no longer sufficient to just do a surface antigen and a surface antibody. You get a surface mutant, or you just undiagnosed the occult Hep B. So if your anti-core total is positive, you're obliged to pursue with a viral load. And even if the viral load is negative, when you're going to dish out high-dose steroids or power guns in immunosuppression, you have to get hepatology involved to counsel about Hep B flare risk. And most of these cases end up going on a Hep B prophylaxis. And in this day and age, your Hep B prophylaxis is super expensive. Your atacabir is $10 a tablet. So the worst thing is that, or the good thing is that kidney function is good, they end up going a higher dose, so it's very expensive. So you often involve the social worker early, and you better involve them early, because outpatient, you want to get a social worker, it's very hard. So inpatient, think about all these things and cost for the patient, and then get some of these things sorted out for us. Not just kickstart the whole process to make us life a bit easier outpatient. And then think about the Hep B issues very, very vigilantly. Number two, in this region, TB is endemic. For goodness sake, at least have an X-ray done, or consider a TB quantiferon. Now, I don't know this TB quantiferon, how supported is it by ID per se, but we started doing it for our patients to give us a hint whether any forms of additional prophylaxis need to come in. The third thing, now, Bactrim is a very, very cheap drug. Bactrim is a very cheap drug. Well, I do appreciate that some patients are allergic to it. I do appreciate that sometimes our G6PD status wane over time as we get older. I do appreciate that some of these patients may not be properly screened last time, and then we miss some G6PD deficiency. I also do appreciate that trimethoprim can cause hyperkalemia. But hey, PCP pneumonia in an immunosuppressed host is very high mortality. Are we really not going to offer PCP prophylaxis? Now, there are two sides of the story. Some some docs believe that Bactrim induces tubular interstitial injury as well, and that's reported in lupus cohort. So not everyone shares the same threshold. A lot of our practice comes because of the influence of kidney transplant practice, because all our patients all go on PCB prophylaxis because of years and years of immunosuppression. But if I'm giving someone high dose steroids, I will offer PCB prophylaxis. If I'm not confident, I may check a G6PD level first, do appropriate counseling before I dish it out outpatient.
Okay.
All right. I will at least make sure that I don't miss the diabetes, or I will make sure that I do not miss the metabolic syndrome. If someone has a impaired fasting glucose, hey, your steroid is going to cause hell, no? Should you not even teach the guy how to monitor the glycemia before you go home? Because outpatient, you want me to teach how to monitor glycemia, I tell you it's very, very, very hard. I don't know who to send to. I don't know whether people are admitted to get trained in glycemia monitoring. So inpatient get the chance, no? They have to maybe buy a glucometer from somewhere and then refer to diabetic nursing or what to get them counseling to know how to test it, and then they come to us clinic with a reading. Because we cannot adjust based on HbA1c. It's not possible. That takes about a few months. We need some ready glycemia count so that we know whether we dish out insulin when our high dose steroid. And the sugar, the glycemia levels will also swing our threshold to push down the steroids and introduce non-steroidal agents early.
Okay.
So the metabolic risk take a factor. You cannot go without a hydroxyvitamin D baseline. Come on. You need to at least know what's the osteoporosis risk. We need to know the bone health. Appropriate individuals, post-menopausal, older group, please have a baseline BMD or at least get an appointment. Because you need to wait for an appointment for a bone mineral density check. We need to know these things. We need to know your vitamin D, whether it's optimized or not. Have you counseled them on the risk of immunosuppression? Have you counseled them on the bone risk, fracture risk, AVN hip, osteoporosis, glycemic risk, hypertension, viruses, infection? Do you even tell them that they cannot eat raw food? I cannot have the patient going out on high dose steroids, going to eat laksa in the afternoon or taking salad, uncooked food. You can't do that. You got to tell them all these things. In your older patients, have you thought about age-appropriate cancer screening in some time to come? Do you counsel about all these things? So I need someone to tell them, and I need the doctors to appreciate that these drugs are not without risk. You have to tell them that these are things to be mindful of. Beyond steroids, calcineurin inhibitors share a competitive risk of hyperkalemia and a raised creatinine by virtue of the fact that it induces vasoconstriction, renal vasoconstriction. The higher dose you want to achieve, you end up having more problems. So someone needs to tell the patient that, look, we are giving you something that is, well, nephrotoxic, but hey, it is not meant for super long run. We will weigh down the dose appropriately. Is to reduce your steroid dependency, because steroids are also a very nasty drug. Tacrolimus is more expensive. Cyclosporine enjoys more subsidy, but cyclosporine can cause, hair growth, gingival hyperplasia, they get some skin keratosis, Tacrolimus got less hair, the ladies like it, but more expensive. So these are things that we think about. And ethnic group, Malays need higher dose. You know that higher dose comes with more cost. So these are things to think about. You want to dish out cyclophosphamide. Do you send the young boy or not? Okay, not young boy. Do you send the adolescents to go and do sperm banking? You counsel them about sterility, because these are not evident in months. This is when they form a marriage. They want to form a family, and years later they come to, hey, I can't get a kid. No, so these are things that we think of, and I find it very, very hard for ladies, because to induce to harvest the oocyte, you need to induce ovulation, right? So the one is a bit tricky. So I don't know how to do it. But at least the main one, we send them to go and do sperm banking, or think about some of these things, consult gynae. Are there things that we can do to help these guys? And rituximab, high cost drug. Do we need to check a B cell subset? Do we need to train the B cell subset to look for appropriate reduction in your B cell suppression to CD19 and CD20? Mycophenolate, cell set can cause diarrhea. How do you know the diarrhea is not because of infection or because of the drug? So these are things that I feel that we probably want to focus on the risk. So there's a saying method. You take care of the complication, you let the benefit take care of it by itself. You dish out the medicine, you better be the one to know the complication and tell the patient on head to toe. And then when you come to see in the clinic, you better know all these complications and look out for them. So in the crux, I feel that immunosuppression, well, the indications, etc., is beyond the scope of this talk, because every different disease got all their own well-defined regimen, but it's not about risk. And giving steroids is a really hated thing. I really hate steroids, and I just hope that all these things and the metabolic infectious risks are all well thought of, and the patients get all this already counseled, already prepared. Bone health is a problem, and just make sure in the long run you do not lose sight of the age-appropriate cancer screenings.
Okay. Yeah. Thank you. I think you've covered this question. Actually, this would be the last slide that I kind of added, and you kind of alluded to it, but I think one of the problems that we face sometimes is a patient has DM, has nephrotic syndrome, and then the question is, when do we say that, oh, it's due to the DM, versus like that we should be pursuing further? Is it based on the time course, associated microvascular disease that will give us a bit of an idea, or it's just bottom line difficult to tell, and you may just, if appropriate, consider a biopsy?
Yeah, there are studies done on this, but I won't quote studies because these are common sense things. So that microvascular diseases like proliferative retinopathy and it shares a 70 to 80% correlation with some degree of nephropathy as well. But having said that, nephropathy doesn't protect you from other things.
Yeah.
Now, my challenge is how do you know whether it's retinopathy? So it's when you click the eye notes,
yeah,
you don't know what they're talking about. No? It's like a different world on its own. No? Then you see all this round picture and then the four vessel and then a lot of dots here and there. So but usually when you see a lot of crosses there, it means that they did some laser. I don't know. So sometimes I have to call the eye colleagues and ask them whether are there really something that we are concerned about. Now, in general, if the patient tells you that they are still on the yearly eye screening at polyclinic or primary care, it is not likely that develop any significant retinopathy.
Okay.
Once they develop significant retinopathy, they'll be referred to tertiary care. That's what I found, or at least to Jurong Medical Center for further treatment. Then the follow-up becomes more frequent. Yeah. Then so if you just establish that first. Now, very hard to ask for neuropathy. I find it very challenging. Once you ask them whether any part is numb, they tell you everywhere is numb. Then you are stuck there, no, and then you're going to refer KN kind of thing. So maybe we should not ask the question. Just a thought. Now, the duration of diabetes is interesting because you can never confidently tell when it started. But if your patient can tell you that the proteinuria started well before they were in the diabetic era, that at least tell you that there was something brewing for some time to come.
Okay.
Or type 1 diabetes, you can know the onset, you know the duration to come. But I find duration highly unreliable. So I look out for microvascular disease complication. At the same time, I look out for macrovascular disease complication. Why do I do so? Because I feel that when you handle a patient, you better handle the patient overall. It's very strange that you treat an organ, but you miss the bigger pictures or macrovascular disease. So these guys will need good cardiovascular disease, medicines, statins, aspirin, etc., breast blockade, whichever. Then you have to decide, are there signs of glomerular hematuria? Is it bland? Is it bland and just proteinuria? And someone told me before that the heavy proteinuria in the diabetic nephropathy, it goes hand in hand with kidney function decline. So when you click your chronic disease registry, you look at the beautiful creatinine trend and the proteinuria trend. You'll see this bizarre picture where this guy's creatinine is normal for some time. Then the A1C always in the red, 8%, 9%, 10%, some bizarre numbers. Then the albumin also very high. Then after a while, you start to see the creatinine increase, like from 50, then one finally becomes 60, then 70, so normal. Then 80. Then when you look at the lower portion, the blood pressure becomes higher and higher. It is very beautiful. It's like drawing, like drawing a mountain, and then you draw the clouds, then the rain comes, then the sun comes. It's very beautiful. You see a creatinine rising, then the blood pressure also rising, then the proteinuria getting higher and higher, Then as the higher the creatinine goes, the A1C comes down, It get better and better, You know what I mean? So it goes higher, then until it's very high, then they refer to you. It doesn't make sense, Cannot be, it doesn't make sense, But once I see this kind of picture, then it come to us, and then creatinine is really elevated, protein is heavy, there is no so-called active glomerular hematuria. When you do the ultrasound, somehow these diabetic kidneys are all normal size. I don't know why. They're all normal size. They are not scarred. They're all normal size. I don't know whether it's the nature of the disease and how it develops in the kidney, in the histology, but the kidney is not normal size, but you see some echogenic component. Then it smells to you that this guy is just reeking of diabetes, Like you ask them to come to clinic, then they are wearing shades, Or you ask them to read something, they cannot see properly, Then you see them walking, then maybe the muscle a bit wasted at the extremities, indicator of neuropathy. You need to use your intuition sometimes, but I still go back to the same generic answer, but right, anyone in doubt just offer a biopsy. Okay, but that aside, if you see someone that come to you, your head to toe, you are selling a diabetes, and you just want to focus on getting that right, then I think maybe this guy don't biopsy first, but do other things first. Something like that. But if you see red flag, or glomerular hematuria, unstable kidney function, rapidly decline. Albumin, boom, super low suddenly. Suddenly become anasaka, suddenly, or went to 8K, blood pressure uncontrolled.
Yeah.
Or you have skin vasculitic rashes. No, then some of these things are become beyond a teaching talk.
Yeah.
It becomes how well you know your patient.
Yeah.
You know the computer patient or you know the patient better. No.
Yeah.
So go to the patient and find out all these things. We have biopsy of someone now with amputee, but and found with IgA nephropathy. Then they give steroids. And you know what happened? You give steroids, the sugar, the schlag, wow, damn high. Get infections, then get admitted for hyperglycemic crisis. You end up causing more problems than anything. But I mean that's beside the point.
Yep.
Yeah, answer your question. Sorry, what was the question?
You did. In terms of when do we think that DM is the cause of the nephrotic syndrome. So actually, this would be the last slide. Hazel, do you have any questions before we wrap up? So in terms of do you have any take-home points for the junior doctors or residents when it comes to glomerular diseases?
I think up to this day and age, I'm still getting confused myself with certain things. Sometimes I don't know whether I'm getting insane or what. But I don't think anyone has a good grasp on glomerular disease. I must tell you that up to this day, when I see some of these less common cases, I'll also be sitting there reading up to date. Honestly, I'll be digging out literature. I'll be discussing with colleagues. I think we shouldn't let pride get into the way of managing a patient. Where you need help, you discuss. You talk to other colleagues who have seen similar cases. You talk to your division at meetings. You present the case, discuss. Be ready to take criticisms and for choices that you have made. At the same time, you do not fear to exert a point that if you are firm with your assessment and yet don't be defensive and accept opinions and recommendations. But at the same time, think about the therapy you're giving the guy. Think about the cost for him. Think about the side effects if you had to handle for this patient. What are you going to end up maintaining the guy with? Can he live with the drug? What are some lifestyle measures? These are diseases that take years and years and years down the road to treat. They'll be stuck with you for decades if you're still in public service.
Yep.
So I think some of these things are very more important than the rest. You can just go and read out at your leisure. Everywhere there are articles nowadays.
That's true. Okay, Ken. That's really helpful. Thanks so much, Dr. Chua.
Thank you.
No, any last questions, Hazel?
Nope.
Okay, Ken. I will stop the record.